So this is part 2 of GU disorders. So the health history we want to ask when we're suspecting a UTI. Remember, infants and young children, their symptoms tend to be vague. So we're going to ask about feeding. As the baby started not eating well, poor feeding, vomiting, poor weight gain, all of those things. And now we get into the more common things that you think of. Urinary frequency, right? That urgency and frequency and pain with voiding. Incontinence in a previously potty-trained child. Persistent diaper rash. It's just going to be irritating. Fever, that odoriferous urine, so bad, strong smell, blood or blood-tinged urine. So some of the things that contribute to a UTI that we can do something about, or do some teaching about. Little girls have UTIs partly because they have such a short urethra. Irritation on the surface that promotes germs. It's just a very short distance into the bladder. So we don't want to get germs from the rectum. So don't wipe back to front, wipe front to back. Boys who are uncircumcised are higher risk. So what do we want to teach them? The same thing, clean from the tip down the shaft, not the other direction. But we also want to teach them don't retract the foreskin, not on an infant. It doesn't retract easily. It shouldn't be retracted. You just leave it until it's able to retract easily. And by then the kid can do it themselves when they're in the bathtub. Urinary stasis. This is our biggest problem. So what are we going to teach a child is do not hold your urine. When you need to go, go. Concentrated urine. The more concentrated it is, the easier for germs to grow in there, so increase the child's fluids. Distended bladder contributes to UTI, so again, teach the child, do not hold your urine. Vesicoureteral reflux is when the valves don't close right and we let that fluid backflow. This, the more distended the bladder is, the valves don't close right, so do not hold your urine. And sometimes that's not the issue. Sometimes there really is a problem where the valve is misshapen, just doesn't shut right, and on those kids they will do surgery to fix the valve. Constipation. This compresses everything, so let's avoid constipation. Increase fluids, increase activity, increase fruits and vegetables. And then perineal irritation. Particularly in little girls because of that short urethra. So avoiding things that cause perineal irritation. So avoid really tight clothing or really tight diapers. Make sure underwear is cotton, not nylon, and no bubble baths or harsh soaps used in the peri area. So enuresis. This is an issue for older kids, school-age kids who are still wetting the bed at night. So they have incontinence past the age of toilet training. We want to do things that like limit chocolate and caffeine, so limit those diuretics. No fluids after dinner. Make the kid void before they go to bed, and many parents say then they will get the child up to void again during the night. And for a lot of kids, just doing that over time will work. If it doesn't, we can do things like a bed alarm. So this is a picture of an alarm that goes under the sheets. As soon as the child starts to wet, it alarms and wakes them up to get them up to go. And if the alarm doesn't work, there is medication we can try. Nephrotic syndrome. With kids, we're usually talking about minimum change nephrotic syndrome, which means permanent renal damage does not happen. So the characteristics are massive proteinuria, hypoalbuminemia, and those cause edema, and then hyperlipidemia also goes along with it. So here's a little diagram. The problem is the membrane, the glomerular membrane gets damaged and lets all the protein spill out into the urine. So there's our proteinuria. Because it's spilled out, it's not in the blood. So hypoalbumin is our most common, or hypoproteinemia. And somehow that stimulates the body to make more lipids, but because we don't have that protein in the the bloodstream, we lose that oncotic pool, fluid moves out, and you get the edema. And if with nephrotic syndrome, our problem is, even though they're very swollen, they're hypovolemic. Intravascularly, they're hypovolemic because they've lost that oncotic pool. So even though they look puffy, that's out in the interstitium. Inside the vessels, they're hypovolemic, and that kind of triggers another response that contributes to the edema happening. So our problem, we just said this, normally that glomerular membrane's impermeable, and so it starts dumping proteins, especially albumin, and it gets lost from the bloodstream, and you see the fluid shifting. So hypovolemia and then ascites and edema is what the parents, they're going to come in for the edema, right? So the treatment of this is steroids. That is our first and best treatment. The problem is it can reoccur. A child can relapse and have it happen. So if they've had it before, they're at higher risk. Diuretics are possible. Fluid restriction, not initially because of that hypovolemic state intravascularly, but down the road, there may be diet, maybe a sodium restriction if there's a lot of edema. All of these are maybes, but steroids are for sure. So, and steroids, like usual, right? When you're on steroids for a long time, we worry about infection, and you have to wean them off slowly. You can't stop them suddenly. And they are usually on this for months. Usually we see an improvement in the first few weeks, and then we keep them on and wean them off slowly over months. And if nothing else is working, they can move on to immunosuppressant therapy. Okay, acute glomerulonephritis. So this happens most often after a strep infection. So this is why we want to treat strep early when kids get strep throat. Occasionally they didn't have the throat first. It just landed, the strep went straight to the kidneys, but usually it's post 1 to 3 weeks after strep infection. So there are some other things that can trigger it, like having lupus or sickle cell disease, but for most of our kids it's going to be strep is the culprit here. So they get generalized edema, but this is because the glomerular filtration gets blocked. The vessels get all plugged up with platelets, and then they're not filtering through the kidneys, so they're not making much urine, and they swell up. Kids often start periorbital first. That's where kids, you see a dependent edema on adults and ankles. Kids are going to swell where the tissue's the stretchiest. So that can be around the eyes, the face, especially in the morning, and then once they're up and moving, it may spread down to the lower extremities. We're going to see hypertension with this, and that's because they're retaining so much fluid. So you're not going to see that with the nephrotic syndrome. You're going to see it with glomerulonephritis, and you're going to see oliguria, right? Severely reduced volume of urine. So what you do get is going to be dark, smoky dark urine. Looks like tea or cola. We do also get what urine there is going to have some protein in there, because we do get some spilling of the protein. So nursing management for this, the problem, we're worried about that hypertension, so we need to monitor their blood pressure. They probably are on medication for that. We need to monitor the weights. If you remember, that's our best way of determining how much fluid a child is retaining or losing. So accurate I and O, abdominal girths to see how swollen they are. This one we are likely to do a low sodium diet and moderate protein. They're going to be susceptible to infections. We really want them on bed rest during this while they are in an acute state chair. Oh, I didn't realize that was the last slide of that. Okay, hemolytic uremic syndrome. So this often is preceded by a diarrhea illness or kind of a colitis kind of thing. So this is microthrombotic events in the kidneys. So the kidneys get all plugged up with the platelets, and then that causes the acute renal failure. The anemia part, so we're going to get the thrombocytopenia. I'm kind of jumping around, sorry. The thrombocytopenia, because we've used it up. We've plugged up all the kidney vessels with those thrombocytes, making the acute renal failure. The hemolytic anemia is because the red blood cells get stuck in here and broken apart. So often we don't know why this happens. It's idiopathic, can be inherited. So if the parents had it, they're more likely. Certain drugs can trigger it. Certain malignancies can trigger it. Can happen if there's been a transplant or malignant hyperthermia. Malignant hypertension. That's not the surgery one. Okay. So the treatment for that usually is peritoneal dialysis. And this is where we take the solution, and it's designed to put into the peritoneum and just allow passive diffusion. So we're trying to pull out fluid. So we're going to make this hypertonic so that water comes to it. The electrolytes and everything are going to be set so that we pull out what should have been peed out and hasn't been. So the doctor will order a certain volume to infuse over a certain amount of time. Dwell time, you just leave it in there to let the diffusion happen, and then a certain amount of drain time. And at the end we weigh this. We know exactly how much we put in, and we're going to weigh this to see how much comes out, right? We're trying to pull out fluid. We should get more out than what we put in. So restoring fluid and electrolyte balance. The things we're going to do: monitor vital signs frequently. We can check urine-specific gravity. How concentrated is it? Ensure that their diet meets their requirements, but also can support their growth. Strict I&O, diuretics if they're ordered. When urine output is restored, they may have quite a significant diuresis. So be expecting that, right? Electrolytes get thrown off when the fluids get thrown off. So if they're not peeing, we're worried about hyperkalemia. They're retaining potassium. We're also worried about hypocalcemia, so calcium dropping low. We may have to give red blood cells because we do get that hemolytic uremic syndrome. We get that anemia with it. So we may have to transfuse. And if the peritoneal dialysis isn't working, they sometimes do hemodialysis. Usually after this is resolved, they're fine though. It's just getting them through this acute renal failure phase, and then they're going to be okay. So circumcision. Let's move on to anatomical things. There is a decreased incidence of UTIs and sexually transmitted infections and AIDS and penile cancer from doing this, but there are occasional complications. Can cause problems with the urinary meatus, or taking off too much or too little of the skin, or doing other damage. So basically, the American Academy of Pediatrics says it's a wash. Parents should choose which one is best for them, but there's not really a medical indication. And they were saying that for a long time. Now they're leaning towards saying there's maybe small benefits more than the risks to go ahead and circumcise, but still not something they recommend strongly. Testicular torsion. This is a twisting of the testicles. This is an emergency. It twists, it cuts off the blood supply, and usually this is teenage boys that this happens to. So it's terribly painful, and they need to be seen quickly.